Good evening, everyone. I'm Elizabeth Ford. I'm the office manager here at Spinal Diagnostics, and welcome to Advancing the Treatment of Pain webinar. We are hosting this in partnership with Boston Scientific, and we have two speakers for you tonight, Dr. Jason Anderson and Dr. Robert Heroes. And I'd like to take a moment to thank you so much for joining us this evening. It's so beautiful outside. Thank you for being inside with us. During the presentation, feel free to submit any questions that you have in the Q&A section at the bottom of your screen. Those questions will be anonymous for your protection, so don't worry about that. And we will plan to answer as many as we can at the end of the presentation. A recording of this webinar will also be available in a few days on our website for if you want to review it or recommend a friend to see it after you've seen it. And we'll let you know if you have any questions about that at the end. Now that we've got all those particulars covered, let me introduce you to Dr. Jason Anderson, who will be starting us off this evening.
Thanks, Liz. Thank you, everybody, for showing up tonight. As Liz mentioned, it's a very nice day outside. Thank you for joining us. Today, we're going to talk about treatments for chronic pain. And it's one of our favorite topics in the fact that we have a real passion for helping individuals that have chronic pain, that have tried a lot of different treatment options and just haven't gotten anywhere. So we try to focus on treatments that are minimally invasive and also provide results. And I think that's missing, or a lot of the education hasn't been out there about these different treatment options. So tonight, we're also going to also go over things you can help discuss with us at your next appointment, and also learn about different types of chronic pain, what options might work best for your situation or for a loved one that has chronic pain. Next slide. So really, chronic pain can be disabling, not just from the pain aspect, but also in what it keeps you from doing. And that can range from what we call essential activities, like doing basic tasks around the house or getting dressed, to something a little more advanced, which is being able to work or be productive, playing with children, grandchildren, doing outdoor activities such as walking or hiking, golf or tennis are big ones that I hear a lot. Gardening is another big one. A lot of patients love gardening, but just can't get out there because it causes so much pain. And then being sexually active. A lot of times pain just keeps people from enjoying activities that they want to with other loved ones. And our job as physiatrists is to help patients get back doing activities they want to do, and being able to help control chronic pain, it helps us to do that. Next slide. So if you have chronic pain, you probably have tried a variety of different things. One of the first line things that you will be offered are medications such as NSAIDs, which are your ibuprofens, your Advil, Aleve, naproxens, physical therapy. You may have tried a TENS unit, which is an electrical stimulation device, which helps distract the pain, but doesn't really control it. Opioids are a big hot topic. Some people have been on them for years and they're just tired of them because they create so many other problems. It can cause constipation, sometimes just unclear thinking. But some patients feel like there's no other choice. Sometimes they've also been to other pain clinics or to surgeons, and they've either had surgery interventions, or they've tried drug pumps, or they've been to see us and they've had nerve blocks and multiple injections, or they've seen other pain clinics that do those things and are frustrated because they're not getting the relief that they want. Next slide. So before we get too far, it's important to understand that there are a couple of different ways to view chronic pain. One is there a mechanical component to it? Does it occur with or without a trigger? Or is it there just all the time, no matter where you are, you can't escape it? Maybe some positions make it a little worse, or if you're in bed, tired and sleeping, the pain is actually worse because like your ability to hear very quiet noises at night, sometimes pain intensifies because there's no other things around to distract it. So it can have a mechanical trigger, or it can be there all the time. Mechanical trigger, like I said, is when you have pain in certain positions. Neuropathic pain is what we think of as nerve generated pain. So numbness, pins and needles, shooting, burning, stabbing pain. Sometimes you can have weakness because it's mechanical, because you're trying to avoid the pain. Every time you take a step, you have severe pain. So you feel like your leg's going to give out because you're trying to avoid the pain. Or you could actually have true weakness where you have foot drop, or you have the inability to push or pull with your arms if you're having a neck issue. So there's a variety of different pain generators that work differently, even though they both cause chronic pain. Next slide. So now we're going to talk about 3 different treatment options that you may not have yet tried. One, I would say, is more for a purely mechanical problem, which is radiofrequency ablation. And then we're going to talk about indirect decompression, which is kind of a mixed picture. You can have neuropathic symptoms and a very strong mechanical component to it. And then finally, we're going to finish with spinal cord stimulation with Dr. Hiros, which is more primarily for neuropathic pain. Next slide. So radiofrequency ablation pain management has been around for probably the last 20 years or so. It's the application of heat to a very small area of nerve tissue so that nerves no longer transmit the pain signals. We call it burning the nerve, but that's just an oversimplification. It's a minimally invasive outpatient procedure. We use a little probe, like you can see in the diagram below, that's a needle-like, and we place that probe over a very tiny nerve branch in a very safe location to do so. After we burn the nerve will slowly die off and then eventually stop transmitting the pain signals so that you have relief of pain from that joint until the nerve grows back. Now, you may have tried medications and steroids and that failed to control the pain, or you just don't like being on those medications, or you can't take them. In order to do radiofrequency ablation, we would do a couple of diagnostic blocks in that area to deaden the nerve temporarily to mimic what it would be like if the pain went away completely with the radiofrequency ablation. So this typically just works for joint pain in the back, pain or in the neck, and it's pain that typically we associate with osteoarthritis or pain that sometimes is worse first thing in the morning and associated with stiffness, like the gentleman in the picture there, and then eases up with activity through the day and then gets worse again in the evening. Now, once you've had radiofrequency ablation, it typically lasts anywhere from 6 months to 18 months. And then that procedure can be repeated when the nerves regenerate. Next slide. So now we're gonna talk about a different issue, which is neurogenic claudication due to lumbar spinal stenosis, which is just big fancy terms for nerves getting squeezed or pinched in the spinal canal or where the nerves exit. So next slide. One of the characteristics of neurogenic claudication is pain that occurs when you're standing or walking. Now, a lot of times it's because the spinal canal, I don't know if you can see here, but the spinal canal runs through the center here. And this is the back side of the spine. This is the front side. Sometimes you can have narrowing in that spinal canal that gets so severe that every time you get upright or stand, that narrowing just squeezes like a boa constrictor that spinal canal. Or it can cause the same kind of narrowing where the nerves exit on the side. So when you bend forward or you sit, you get relief because it opens that spinal canal or the holes where the nerves exit on the side. So this is characterized by pain with walking and standing, and then relief with bending over slightly like on a shopping cart or with sitting. This is also the condition that patients often complain makes them look quote unquote old because they're bent over and they want to stand straight, but they find themselves bending more and more as they continue to walk or stand for a longer period of time. And then also they have the social stigma or even stigma from their spouse or loved ones who tell them they look old because they're bent over when they walk. Down at the bottom there are some symptoms that patients have reported. They report that their sciatic pain in their legs is so severe they couldn't walk more than 100 feet without having to sit down. Pain meds stop working because this is a mechanical issue. Pain meds typically don't work very well for this. And then when nothing seems to work, patients often end up staying at home and not doing things. A lot of patients say they can't get all the way around the store because they just can't walk that far. Sometimes they fight other family members to who gets to hold the shopping cart so that they can try to lean over on it and try to get some relief. Other patients have tried medications like gabapentin or Neurontin or Lyrica or pregabalin. Some of these medications make people kind of confused or having trouble concentrating, and patients don't like being on those. Other patients have tried multiple injections and they just didn't get better. And it's because the real problem's in the back. Another patient here, the last one, they had numbness and tingling in their hip. It goes all the way down the leg and foot. Started years ago and it's becoming worse. So this is like a slowly progressive condition. A lot of times this has just slowly gotten worse and worse with time and just kind of crept up on them. Another common complaint I get is patients will report having pain one day in the left leg, let's say, and then another day on the right side, can't explain it. And part of that is because every time the spine bends forward, it releases the nerves that are freely floating in the spinal canal. And every time you get up, it may squeeze a different nerve. So they're not going crazy. That's just one of the symptoms. I've also had patients report having water-like sensation running down their legs, warm or cold, and that can be very disconcerting. Also, patients report a lot of times having trouble with balance. And that all goes along with this condition. Next slide. So what is lumbar spinal stenosis? I kind of tried to explain it a little bit before, but it's a gradual narrowing of the space in the spine where the nerves pass through. And it can cause pinching in the lower back nerves, resulting in the neuropathic symptoms I described earlier, which are tingling, numbness, weakness, and pain. And like I said before, it can be in one leg, both legs, or just in the low back, or in both. And relief is experienced when patients bend forward slightly or with sitting. This is just a very common chronic degenerative condition. And it's just a result of multiple things happening in the spine that gradually worsen. And then what suffers is the spinal canal here in the center. And as you can see, the healthy picture where there's a lot of nice room, like on this model. And then the stenosis picture shows in red where nerves are getting pinched or the central canal is getting narrowed. And then on the picture on the right, they show the difference between a healthy nerve, which has a nice big opening, versus pinched nerves that are getting squeezed. And that results in pain going down into the back and into the legs. Next slide. So one of the solutions we have for this is the Vertiflex procedure. And it's a simple, minimally invasive treatment, which can provide effective long-term relief. It's FDA approved. I've been offering it here for over a year. It just requires a small incision, about the diameter of a nickel is about an inch, inch and a half incision. It's a same day procedure. Usually you can go home within a couple hours, maybe 3 hours. It doesn't require any removal of bone or tissue. It has a speedy recovery time. And if for some reason you didn't like it, it can be removed. There is a low risk of infection or complications, and to help avoid infections, we also give patients IV antibiotics on the day of the procedure. I also put antibiotics into the wound, and then also give patients oral antibiotics to take for a few days after the procedure. This can provide long-term relief, and it's also important to know this isn't just a treatment that only a few people had. Over 10,000 patients have had this treatment since 2016. And it does have 5 years of research data behind it. So what they're showing on the model is, or in the pictures is, here's the spinous processes. These are the bumps that you feel in the back. Often, as the spine collapses, you can see that the space between the spinous processes gets more narrowed. And the Vertiflex Superion spacer can go in between and prop that open and keep it open, like when you're bending forward or sitting down. That allows more room in the spinal canal and also more room near where the nerves are exiting on the sides. Next slide. And here it explains what the results are of their research studies out to 5 years of clinical data. 9 out of 10 patients have been satisfied with the Vertiflex procedure at 5 years. 85% of patients report a drop in their use of opioids. 81% report improvement in physical function, and 75% report reduction in leg pain symptoms. I would say in the patients that I've done, the 9 out of 10 number is accurate. Overall, patients have been very satisfied with it. It's helped them avoid surgery, or if they can't have surgery, they've been told by surgeons, look, you're old, get over it. I can't do a surgery on you. We've still been able to do this procedure in patients who are in their 90s. I can also do this procedure with just local anesthetic if patients have issues where they're not a good candidate for any sedation whatsoever. As they show there, Bill, he reports having no more leg pain, which was killing him before, from his hip to his ankle. It's completely gone. I had a patient very much like Bill earlier today who was in the same boat at 2 weeks out. Gloria, in the note there, says on the day of her procedure, she went to visit the Butterfly Park in Scottsdale, and she feels happy and walked around with any problems. Because this mechanically addresses a mechanical problem, often patients have almost instantaneous relief. I've had a couple of patients that had continued pain for about 2 weeks, but in each case, they did very well. Sometimes the nerves have been squeezed for so long that once you release that pressure, it allows the nerves to get blood flow that they haven't had there for a while, and the nerves waking up can be very intense. But that has usually only lasted a week or two, and those patients have done very well. So that concludes what I was going to talk about on Vertiflex, and now we'll turn it over to Dr. Hiros.
Thank you so much, Dr. Anderson. Our next speaker is Dr. Robert Hiros. He's going to continue our theme and talk about spinal cord stimulation.
All right. Thank you, Liz. I really appreciate that. So I just first want to say thank you, Dr. Anderson, for that great introduction on radiofrequency ablation and spinal stenosis and how we can treat that. And I think one of the kind of the take-home messages from all this is that there are lots of different treatment options, but each one of them is really aimed at a certain type of pain. So I think at Spinal Diagnostics, what we're trying to do and do the best we can with is try to match up the right treatment for the right patient at the right time. And if we can match up those three things pretty well, then I think we have a better chance of helping you. So let's go to the next slide and we'll start talking about spinal cord stimulation. So the first question is, well, what is this? So a spinal cord stimulator is really just a pacemaker for pain. And I think most people have heard of a pacemaker, and this is very similar. And you can see the little silver batteries there. So just like a pacemaker battery, the stimulator has a battery, and then it has long electrodes, which you saw in the previous slide. Now, in a cardiac pacemaker, the battery goes in the chest and the wires go into the heart to beat the heart. Now, in a spinal stimulator, the battery goes in the love handle. I don't know about you, but I definitely have a love handle. So that's where my stimulator would go. And the wires go into the spinal canal itself. And the electrical signals basically act as a roadblock for the pain signals. So in your feet, in your legs, your back, and your buttocks, all of the pain that you experience there goes into the nerves, it goes into the sciatic nerve, and then it goes up into the spinal cord. And all that pain information gets relayed up to your brain to tell you that you're hurting. Now, a spinal stimulator is kind of like a roadblock. It's basically using this little electrical signal to try and reduce, block, alter the pain signal before it gets to your brain. Now, that kind of brings up an important point. A spinal cord stimulator is not a cure. It is not a fix. Now, and I'll get into it in a little bit of, what the appropriate patient population is for this. But it's always important to think of, the good and the bad. And one of the downsides of a stimulator is it's not a fix. It's not going to cure anything. But if we can reduce pain signals when there are no other better viable options, then we can improve quality of life. So just as in the Vertiflex procedure, this is a procedure that is FDA approved. It's been around a lot longer. This has been around for decades. And the technology has continually improved and continues to improve. At Spinal Diagnostics, we're involved in a lot of clinical research with neuromodulation or spinal cord stimulation, trying to find out new ways that we're able to help people and new indications. Spinal cord stimulation is covered by most insurance companies, and it can really have a lot of great results. It can help people improve their activity tolerance, their quality of life, reduce pain medications. And I really think of this as a quality of life device more than anything else. Now, as with surgery, there's always risks. There's no such thing as any type of spinal procedure that is without risk. So it's about risk mitigation or risk management. And when you get to the point that you're thinking about trying a stimulator, the alternative is usually something like surgery and more surgery, and that's much, much higher risk than a stimulator. Let's go on to the next slide. So this is a safe and effective procedure that is backed by a lot of research over the last, as we mentioned, 40 years. Now, Boston Scientific has done a good job of continuing to push this envelope in terms of clinical research. And this Lumina study that is referenced on this slide demonstrated significant superiority over some other spinal cord stimulator systems, showed significant reductions in pain. And the exciting thing about this is that the pain relief was extended out to 2 years. So this wasn't just a short-term improvement. Next slide. So who is this for? That's really the most important question. As I mentioned a moment ago, you got to find the right treatment for the right patient. So radiofrequency ablation is a mechanical pain issue. It's an arthritic condition from the joints, or that's what it treats at least. Same thing with the Vertiflex. That is for kind of a mechanical issue where there's a compression of the spinal canal. Spinal cord stimulation isn't for those things. This is really for what we call neuropathic pain or chronic nerve pain, primarily in the trunk, the body, or the lower back and the limbs, the legs and the feet. Now, the most common indication for this in this country is failed back surgery syndrome, which simply means that somebody has had back surgery and either it didn't work or it worked for a little while, or unfortunately, there are cases where back surgery ends up making something worse or causing new problems. So it's also not for acute pain. This is for chronic pain. So this is for pain that's been around at least 6 months. And it's not for pain that hasn't really been treated yet. This is for pain that has proved resistant to treatment. So if you've done physical therapy, if you've seen a chiropractor and tried acupuncture or done massage therapy, maybe you've taken a variety of different medications, including narcotics or some of the nerve pain medicines like gabapentin that tend to have a lot of side effects. You've had back injections or epidural injections. So you've tried all of this and you still have this nerve pain in your back and legs. It's been there for 6 months. Maybe you're a candidate for this. Now, the other thing is this is not for mild pain. And that's why it mentions on this slide at least a 5. Now, the 0 to 10 pain scale is very difficult. It's very difficult for us to interpret. It's difficult for you as patients to give a number. But unfortunately, even in 2021, it's the best we can do right now. You cannot measure pain objectively. But that said, the whole point of this is that this is an advanced procedure. It's a pacemaker that goes in your back. So this is not for somebody who's had a few weeks of mild to moderate pain, or even somebody who's had a few years of mild to moderate pain that doesn't really impact them. This is for significant chronic nerve pain that has a big time effect or impact on somebody's quality of life. It can be for other nerve pain symptoms or syndromes like complex regional pain syndrome, for diabetic or any other type of peripheral neuropathy, or let's say a knee replacement that ended up with nerve pain afterward from inadvertent nerve damage. Anything like that can be a good potential indication for this therapy. Let's go on to the next slide. So we like to talk about personalized pain relief, especially with Boston Scientific, because there are some new exciting options. And we're going to briefly just talk about how this works and what you experience with a spinal cord stimulator therapy. The really unique thing about this type of therapy is that you get to try it first. And that, I think, to me, is a big selling point. You get to try it before you buy it, so to speak. So the way to find out if a big 3-level lumbar fusion is going to help, you have to get the big 3-level lumbar fusion, and there's no going back from that. The way to get an idea of whether a stimulator helps is to do a temporary trial, and I'll go into a little bit more detail about that, but I really like that about it. Next slide. So I mentioned some specific therapy types that Boston Scientific has in specific worked on, and they can target different areas of the body simultaneously. And we talk about different types of stimulation, including paresthesia or paresthesia-free. Now, in the first 30, 40 years of spinal cord stimulation, it was all what was called paresthesia-based. And that just means that whenever the stimulator was on, what a patient felt was this kind of numb, tingly, electrical massage, prickly sensation, pretty much from the waist all the way down to the feet. Now, some people loved it. Some people just kind of tolerated it. Some people were ambivalent about it, but some people really didn't like it. And thankfully, over the last 5 years or so, there's emerged new technology that's called paresthesia-free. And that's the type of stimulation that is just as effective without having to feel anything. So to be able to use both of these simultaneously to target different types of pain in different parts of the legs and body is really, really exciting. Next slide. So this is kind of how you know if a trial worked, but the trial is a temporary version of this that's just put in through needles that you get to try for a week. Now, this is a non-surgical trial procedure. There's no incisions. There's no long-term commitment. It's totally reversible, and it's very, very low risk. I have seen complications from spinal cord stimulation, no doubt. Every serious one I have seen had to do with the implant surgery, and you always do the trial first. The worst thing I've typically seen happen from a trial is it doesn't help as much as you want it to. And the therapy isn't perfect. No therapy is. This is not for everybody all of the time, but at least we have the chance to try it out. So during this temporary trial, the wires are put in through small needles, and then they exit the back and they plug into a little external battery. You have a big bandage on your back, and you walk around with that for a week. You have some physical limitations, but for the most part, you live your life and you see what it does for you. Now, what we consider a successful trial The slide says 50%. That is what insurance mandates. So insurance says if a temporary trial gives you 50% improvement, then they will allow you to go on to have this surgically implanted. Now, the different companies may not like that I say this, but I don't like 50%. I don't think 50% is good enough, to be honest with you. My personal goal is 60 to 80%. I think 60 to 80% improvement is a reasonable and a realistic goal or hope. 100% pain relief, not a reasonable goal most of the time, especially considering that when we're doing this, it's for people who have had severe nerve pain for many years that has failed everything else. So realistic expectations, realistic hope is important, and 60 to 80% I think is pretty realistic. Now, how you measure improvement, very, very difficult. As I mentioned earlier, you can't really measure pain. So we use that 0 to 10 scale, but sometimes we do different questionnaires that are standardized that help us figure things out. But really, it's typically the patient just saying it helped. And we ask you what percent it helped, but what does that mean? So as far as I'm concerned, that can be a 60 to 80% improvement in the pain on a 0 to 10 scale. It could be a 60 to 80% improvement in sleep or sleeping that much longer, an improvement in activity tolerance, activity around the house, getting back to work, a 60 to 80% improvement in quality of life, of happiness. It's really how you decide it. But we do want you to feel pretty strongly that there was a good 60 to 80% improvement. Again, whether that's activities, pain medication reduction, sleep, whatever it is. And if you can get that relief during the trial, then I feel pretty good that the implant surgery is an option for you. The predictive value of the trial is pretty good. Is it perfect? No, it's not perfect. So not every single person who has a good stimulator trial does fantastic forever. To some degree, I think that's the nature of the beast. We're human beings and medicine is imperfect. But again, for the right patient, when you've got this severe nerve pain that is really interrupting quality of life on a regular daily basis, you've tried other things, you either don't want more back surgery or it's not indicated. I do think trying this is a very reasonable thing. Next slide. I think that's it. Yeah. So that's all I got, folks.
Thank you so much, Dr. Hiros. I want to welcome Lee and Ryan from Boston Scientific. They're going to review the questions that you folks had for us this evening. We want to get those answers for you. If there's anything at any other time, you can always reach out to the office, but we'll talk about that after. So you can take it away, Ryan.
Thank you, Liz. Appreciate it. Thank you, Dr. Anderson, Dr. Hiros. And thanks to everybody who asked some questions as well. There was a lot of really good ones, and I'll try and get through as many as I can in the time that we've got. I'll start off with the first one. If I already have SCS, is it possible to be a Vertiflex candidate and vice versa? If I already have SCS, can I have Vertiflex, or SCS?
I can take that. Yes, is the short answer. And I've had patients go both directions. Already have SCS and then get Vertiflex and then the opposite. And they, since SCS has been, or spinal cord stimulation has been around a lot longer, we have a lot more patients that as they've gotten older, the spine continues to degenerate and spinal canal stenosis appears, and SCS doesn't take care of mechanical pain. And so Vertiflex Superion spacer has helped a lot. And I think there was even, there is a research study ongoing looking to see the effectiveness of that.
Great, we can move on to the next question. Can either be placed in the cervical spine for neck pain?
So the Vertiflex procedure, no, it's only indicated for the lumbar spine. Part of that is due to the anatomy in that area and how much, for instance, the neck moves quite a lot. The spacer device is not designed for that. And then in the thoracic spine or the mid back, again, the spinous processes are slanted and sloped down at such a significant angle that this device wouldn't stay put.
And then how about SCS? Is that able to be placed in the cervical spine?
Yeah, that is. Now, some insurance companies, just kind of as a straight up mandate, do not cover it in the neck, but it is possible and it is done. Not necessarily for neck pain, but if there is neuropathic pain, so if there is nerve pain down the arms, then that is certainly an option, yeah.
Fantastic. We'll move down a little bit here to the thoracic spine. Can either of these be placed in the thoracic spine, Vertiflex or SCS?
So I'll just hop on the SCS. So when we are treating lower back nerve pain or leg pain, the electrodes actually go in the thoracic spine. That's the area on the spinal cord it tends to work the best. Middle back pain, thoracic pain itself is very, very rarely a purely neuropathic or nerve pain type of situation. So it can be done. The electrodes would go higher. It's just very uncommon. And I'll let Dr. Anderson comment on the others.
Yeah, Vertiflex, the spacer device, is indicated for L1-2, L2-3, L3-4, and L4-5. The reason it's not indicated here at L5-S1 in most circumstances is because despite what this model shows, there's really not a good attachment place here for the device. So it's classically indicated for those 4 levels in the lumbar spine.
Okay, fantastic. Moving on. Are there any physical limitations moving forward after you've been implanted with either Vertiflex or SCS?
I'll take the Vertiflex question. So for 6 weeks following the procedure, we do have bending, lifting, and twisting restrictions. No lifting more than 10 pounds during that time. Once the 6 weeks are up and things are going well, we would then order physical therapy and lift the bending, lifting, and twisting restrictions.
And then spinal cord stimulation is actually fairly similar. One of the things that keeps these little wires or electrodes in place is scar tissue, and that takes a while to grow. So the restrictions that we have during the trial on limiting of really aggressive bending and twisting and turning, we like to keep those for 6 to 8 weeks after the surgery. And then after that, you, for the most part, can go back to your normal life. People play sports and hike and swim and cycle and go back to work. So it's a couple of months and then pretty much in the clear.
Fantastic. Dr. Hiros, this one is probably for you on the SCS side. Patient has a pacemaker. Are they still able to get an SCS implant?
It depends on who you ask. The pacemaker reps will say no problem. The stimulator people will say, well, we just got to be careful about it. But it is possible to have multiple neurostimulation devices in place. I've even seen patients who have a neck stimulator, a cervical stimulator, and a lower back stimulator. Some patients have bladder stimulators for incontinence, and they can coexist with this. We just have to do certain things in surgery to keep everything safe.
Fantastic. Coming back to you again, Dr. Hiros, can SCS be a good solution for shingles pain?
It can. There are certain types of stimulation that I think are better for that type of pain, but it's all considered spinal cord stimulation, so it is an option. So again, if that, that is a very severe nerve pain syndrome. So yes, it might mean we put the wires in a slightly different place, but it is certainly a possibility.
Okay, great. And then if I get implanted with SCS or Vertiflex, am I able to still have other procedures moving forward, injections and stuff of that nature?
With Vertiflex, yes. You can still have other procedures. Yeah, very, very common.
Same thing with spinal cord stimulation. Does not by any stretch mean that you can't have an epidural steroid injection if a new sciatica comes up or something like that. So yeah, it does not preclude you from having intervention in the future.
Okay, great. There were a lot of duplicate questions as far as where this can be placed on the spine, cervical, thoracic, lumbar. I think we answered a lot of those. The ones that I didn't get to, I just want to let everybody know, if I didn't get a chance to answer, please call the number that you see on the screen right now. Dr. Hiros, Dr. Anderson, everybody at the clinic is more than happy to answer these in clinic during a consultation. Thank the both of you so much for answering, and a great presentation. And then I'll kick it back over to you, Liz.
I just saw a question come up about MRIs. Rob, do you want to take that one?
Sure. Yeah. So with the spinal cord stimulators, almost all of them are at least partially or conditionally MRI compatible these days, which means that you can still get MRIs. You just can't kind of walk into any old MRI anywhere and just get an MRI. You typically have to put the device into a certain setting, and the people doing the MRI need to know what they're doing. So we direct you to certain places. But for the most part, yes, MRIs are possible.
And I would just say with Vertiflex, it's not a contraindication at all for regular MRIs or any type of MRI.
That was
Great.
it. That was a good last question at the buzzer there. Appreciate it.
Thank you guys so much. And as Ryan said, we have all the opportunity to answer more questions for you. We have on our final slide here our contact information. I feel like this was really educational for me. I hope it was for you guys, and it gave you some options to help alleviate your pain. Again, if you have any questions, our number's on the screen. It's the 503-885-1515. Obviously, we are not open. It is after hours right now, but we will be open again tomorrow morning at 8:30, and we're open till 5. So you can schedule a consultation with us and kind of go over some more of your options and see if these new treatments would be right for you. Again, you can also request an appointment online at spinaldx.com. And thank you so much for joining us on this beautiful evening. Bye-bye.
Thank you, everyone. Thank you.
Thanks, everyone.